Good afternoon, everybody. Sorry. Make everybody jump. Can I ask if you could take a seat, please? So I'd like to welcome you all back for panel 3. We're going to look at challenges to the full realization of women's rights in childbirth. So to begin, I was asked to tell you my story as to what brings me to be sitting here. My name is Nicola Philbin. I'm British, but in fact I've been away from home for more than 10 years now, so I think I'm beginning to think I just need to say I'm international. My nationality is international. I have a lot of international experience of different maternity systems now, 3 in person. I had my own 3 children in the UK. And my very first was in hospital after a conversation with my doctor who said, "Oh no, I don't think a home birth is a very good idea for a first baby." That was the very beginning of my journey. I then had 2 home births with my other 2 children. I then spent several years in Dubai, being one of the first doulas working in Dubai, which is a very medical system. And I've now spent 5 years as a birth educator in the Netherlands, which is where I currently live. Basically running my own business, helping pregnant parents to prepare for childbirth. So what I try to do when I'm helping parents to prepare is to help them understand and explore their options, to work out the type of birth that they want and that they need for themselves and for their baby, to help them work out how they might find that, and then hopefully to start their family life with the best birth experience possible, to get them off to the best possible start. However, my 7 years as a birth practitioner were preceded by 15 years as a telecoms lawyer. So that's also what brings me here. That, in fact, is really what brings me here more than anything else. I think once you're a lawyer, you're always a lawyer. You can't get rid of it. And I would never have dreamt, it's 8 years now since I went on maternity leave with my 3rd child. I never would have dreamt that I wouldn't go back, and that in fact I would then train as a doula, and that I would find myself now sitting here 7.5 years later. The issues I was involved in then as a lawyer, though, I think are still really, really relevant to the work I do with parents looking at birth. I help with risk assessment. I help others to make decisions about what they need for themselves, support that process using the best available evidence. That led me to then to meet Hermine Hayes-Klein, who's already been mentioned, who is the founder of Human Rights in Childbirth. I met her in Holland in 2011. Again, another, oh, let's just meet for a cup of coffee and look where it goes. She wishes she was here in person, I'm quite sure. And I was then involved in setting up the first Human Rights in Childbirth conference in The Hague in 2012. And then we set up Human Rights in Childbirth as an organization. And I've been serving on the board ever since. I don't think I could do the birth work that I do if I wasn't also a member of Human Rights in Childbirth. I hear so many stories, even in Holland. Everybody goes, Holland is amazing, it's the best place ever. Even in Holland, I hear stories all the time of, I wasn't allowed to, you must be induced. I've had a client who was told, you must come in on Friday to be induced or I'll call social services. So if I didn't do this work, I don't think I would be able to cope, actually. So what I'm really looking to do, more than anything else, though, is actually to try and improve maternity care and improve choices for my own children. I want them to have access to the choices that I had and have access to decent maternity care wherever they end up living in the world. And actually, I wanted to finish with, there was a typo in the program. So against my name, it says birthright lawyer. And I think it should have said birth rights lawyer. But when I saw that typo, I went, oh, I quite like that. So what I really like, I am definitely a birthright lawyer. I want people to be able to birth right, to find the right birth for them. So I think I'm going to stick with that one now. So that's a little bit about me. So we're here for panel 3. And next I would like to introduce Alberta Bacci, who joins us with a long history of having done much work in this field. She spent 10 years working with the WHO's Making Pregnancy Safer program, and is currently a member of the WHO Collaborating Centre for Mother and Child Health in Trieste. She is going to talk to us about her experience in countries where she's worked with development partners to promote human rights recognition in childbirth. Thank you.
Thank you for a kind presentation. And you notice that the program has changed, so I'm instead of the first speaker from WHO Geneva. I'm an obstetrician gynecologist as background, been working in 4 years in an African country, the rest of the years at the beginning of my career in Trieste and other Italian hospitals, and then 10 years in WHO Regional Office for Europe. As this morning was pointed out rightly by Elena, I think, initially programs of international organization and WHO in particular were focusing very much on maternal mortality issue. Safe Motherhood program, for example, who started in 1987, had this first goal, decrease maternal mortality by 50%, and we all know the history of the initiative. The second important program that came out since 2000 started talking about ensuring skilled care at every birth within the context of continuum of care. So the shift was continuum of care and skilled birth attending. But we have I started in 2001 in WHO European Office, and since 2011 I retired, so I work as a consultant in several countries. This is the European region in WHO. You know that there are several regions, the African region, American region, and you see how big. It's not Europe, it's not European Union. It's a huge region that includes all the previous Soviet Union countries and all Central Asian countries. It includes still some of the poorest countries in the world. So you will see some pictures and examples from these countries. How WHO works is WHO is done by member states. So I could not decide I will start working in this country or that country. It's a biennial agreement between the country and WHO, and the country says these are my priority. That could be non-communicable diseases or communicable diseases, HIV, tuberculosis, or it could be reproductive health, mother and child health. So there was no choice from the WHO to decide in which country to work. This was situation of maternal mortality when we started writing the strategy. I just point out one issue is that this darker color are not the real countries in which maternal mortality is higher, is the country who better report. There was huge problem, and there still is a huge problem of underreporting maternal mortality. This was one of the issues we had to confront with. In maternities, this was more or less the situation. The pictures, this is, normal way of giving birth. You see the woman lying on the back, legs on stirrups, enema shaving routine, episiotomy quite routine. Drugs were used without proven effectiveness. Everything was ruled out by general laws and orders called PRICAS that stated, for example, that putting an ice pack, you see the little brown thing on the woman's abdomen, compulsory after every birth to prevent postpartum hemorrhage. Separation was quite a rule. Baby is tightly swaddled and put in another room, separated from the mother. Family members, this is a lucky husband because the woman is on the lower floor so they can talk through the window, but mostly there were no visitor allowed, and so on and so forth. So situation was difficult. It was difficult at political level because there were these binding documents from Vladivostok to Odessa. You recognize the same patterns, and providers used to work in such a way. For the woman, there were not counseling, but there was a series of orders for the pregnant woman, what to do and what not to do. Challenge is session on challenges, how to address this. Some help came from international literature, which was convincing more for the western part of the region, but this was a very important paper. This was Beverly Chalmers' analysis of what women remember as unpleasant during birth. And it's historical, 1998, and you see obstetric tables, open doors, and usually women giving birth facing the door, of course, totally naked and exposed, no attention, painful vaginal examination, loss of dignity, and you see the high percentages of all of this. Disrespect, woman not the most important person in delivery room, being blamed. As a result, in this study, 42.8% of women say they would prefer to deliver at home. What was the major impact? That this study was conducted in St. Petersburg. And then people in the region started seeing the problem from their own point of view. It's not a study run in Denmark or in France or Italy or the United States. This is really talking about us. When translated into Russian, it gave us a good push for started discussing practices. At that time, we were starting to write a kind of document, a strategic approach. There was a global strategy for making pregnancy safer. We prepared a regional strategy for making pregnancy safer, taking into account more and more the issues of quality and not only of mortality as in other parts of the world. And you see holistic approach, important familial experience, valid reason should be there to interfere with the natural process, interventions for pregnant women should be available, accessible, appropriate, and safe. And next one. And the principle of making pregnancy safer is care should be based on scientific evidence, should respect the confidentiality, privacy, culture, belief, and emotional needs of women, should involve women in decision making, and ensure continuum of care. We heard many times these words today, but this was 2004 when the strategy was published, and the difference from the global strategies was an important binding factor for the ministries of health, and many ministries of health took steps to change the precast, the orders, into adopting new technologies. At the beginning, when I heard new technologies, I was like, what is this new technology? Many ultrasounds and incubators? No. New technology, luckily, was getting back to the past, to the real basic thing for ensuring good care for women during labor. Several interventions. Is there a way to see it larger? I'm trying to do like that. And okay, I will try to look at that. Another important step was to put this intervention and this holistic approach in a package, which we call the Effective Prenatal Care Package. This is the first version. Recently, it was updated by WHO Collaborative Center in Trieste and should be online very soon. This is the reference where you can find the previous version, still there. The package was built about providing information, knowledge, skills, practice regarding important care during normal birth and the management of complication, but built into that the holistic approach and the appropriate relation with the woman during labor and birth. No way? If it's not working, what should I do?
It's not changing.
Not changing. And this is.
Maybe click on the slide on the screen.
Okay. It's not.
It's changing on the computer.
It's changing on the computer. Can I have the next slide? Maybe I cannot. Okay, sorry.
Oh, yeah.
Okay. Important part of the course, it was multi-professional. Usually government asked to train our doctors, our professors, and then they will train the others. We set the standards that we train midwives, doctors, obstetricians, neonatologists, nurses, all together. We train the team of perinatal care providers. Otherwise, the midwives are ready to change, but, the obstetrician are not, or vice versa. It's the midwife who really don't want to change. So the multi-professional was absolutely important in the first part. And you see one of the first example of midwives training doctors, which was quite a scandal, but, WHO is quite strong and recognized in that country, so it worked. And the training was very much interactive. It's in-service training, especially at the beginning. It's not the frontal lectures with people sitting in white gowns and caps and listening attentively, making questions at the end. Several exercise, practice on mannequin, but this was the most important part. From knowledge, skills, practice was brought in, both in training, for example, on position during the course, but second part of the course, second week, was going into labor and delivery room and practicing what we learned on the first week this is a woman in labor who's supported by a midwife during the second part of the course. The practice part was the really changing issue that made people not only understand, but also practice in a different way. One more minute. Okay, results was one-to-one professional care. This is one example from Ukraine, and you see the different position, different everything. Delivery room were changed the first day of the course. Companionship in labor. This is example of Tajikistan, not the forefront in social advancement. They said it's a Muslim country. Husband will never come to labor and delivery room. This was the first couple that the new methodology was offered. They adhered, and it was a wonderful, of course, birth. Couples and families involved in the training were called at the end to give to all the staff, not only the trained people, the feedback about their experience of a new birth. What we added is a quality assessment tool. Dr. Lazzarini will speak about this later on, and we have also Dr. Monica Piccoli participated in bringing basic evidence into this tool. And the tool included in the older version a chapter called Mother and Baby Friendly Care. This is an example pre and post assessment in the middle of the war EPC courses, and you see how the scores are increased. Now this chapter is called Human Rights, and Marzia will tell about this. Just as a few results from the interviews. The tool includes interviews to staff and mothers, not only mothers, because also the staff has a say about quality of care. These are mothers' interviews that discover issues of cost of care in countries where apparently, formally, care for birth is totally free, and instead we have barriers to go for care in pregnancy because of the cost of laboratory tests and medicines, barriers of access regarding social issues, mothers-in-law who do not allow the woman to go to care, or mothers-in-law that encourage to use. My mother-in-law suggested that they should consult a witch doctor. It seems some other region in the world, and we are in Central Asia, so problems that we don't usually consider. Problems about information. This is a lady that says, if I had enough knowledge regarding breastfeeding length, I would have breastfed my baby up to 2 years of age. And also some very positive statement regarding the staff. This lady says, despite there are constraints, but I live in a village, so in the hospital I felt like in paradise. So these interviews, we tried to pick up the positive, of course, to support the staff in the changes that they had made, and also things to be changed. Women are very aware about quality of care, and they can compare with past experience. This is another country. I don't put the name of the countries. As you saw at the beginning, it was done in more than a dozen countries in this region and other countries in other regions. This was in a country where 2 assessments were made, and this is the second one after effective perinatal care. I was anxious. It was my second delivery, and I thought it was easier than the first one. I was allowed to drink and eat what I wanted, to choose what position I wanted, to walk, to be sitting, to stay on my back, on my side, to have my husband with me all the time. The staff provided such a kind and full support to me that the only thing they could do was to be at my place and give birth to my baby. It's funny, but it means really that something had changed from the previous time. And baby is staying, this is another mother, baby is staying all the time with me. All care provided to him is under my eyes. Of course, different from the first birth when it was separated. This is my last slide, and I thank you for your attention. These are, of course, Central Asia, this is Balkans, some countries where this assessment was provided. Thank you very much.
Thank you very much, Alberta. That was very interesting to hear. Such a success story in terms of making noticeable improvements. While Nick organizes his slides, if you can. And then you have to put it back in to use this if you want to. Yeah.
It's not working. Still not working. I just need to switch.
I have problems in having the slide.
How do I switch to another presentation?
So we go into this folder. There we go. So if you close that, and it's in here. In fact, it's in here. It's here. It's here already.
No, it's right here.
Oh, yours is the present. Sorry. Yeah. Which in fact might already be open.
There we go. Now, how do I get it up to
Okay.
there?
Okay. So we've already heard from Nick earlier today about the research that he's been doing in Hungary. So he doesn't need much further introduction. I'll try not to interrupt. He is an American obstetrician gynecologist who splits his time between practice and research. And I'm sure at the moment you're very busy trying to write up your results. He's also a current board member of Human Rights in Childbirth. So he's going to tell us some more about the system that they investigated in Hungary, where informal cash payments are made, and also some results from the survey that they have collated so far.
Great. Thanks, Nicola. And so Alberta referenced the topic that I will discuss as a challenge, which I think you can kind of see in the title, The Price of a Free Delivery. It's kind of a purposefully comical and absurd title, but it involves some of the data that came out of our survey that I previously described related to cash payments in obstetric care. I should note that I have done this analysis mainly in collaboration with a health economist. Her name is Petra Bai, and she's an expert at Corvinus University in Budapest on cash payments in Hungary, and she regrets that she couldn't be here today. So I'll briefly talk about what are cash payments, because they have different come in different forms, and I'll talk about cash payments in Hungary, the region, and the results from our survey. So, I didn't realize it was going to do that. So informal cash payments are unofficial. They happen outside. They exchange hands outside recognized tax channels or government channels. So they're not registered with the state. There are no guidelines about how they are done. Nonetheless, so these aspects that happen with cash payments are very much under negotiation. So people are often deciding, hearing from their friends or deciding on their own when to give the payment, to whom, how much. So you can imagine all of the questions that come into mind when it feels that this cash payment is very necessary to get a quality birth, and then this other level of decisions you need to make. These cash payments are quite common in Hungary, and there have been different theories about what maintains them. An economic theory that doctors are underpaid, so these cash payments will increase their salaries, and also some sociocultural theories that this has been kind of a long-term tradition amongst Hungarians, and Hungarians particularly express their gratitude for their medical care in the form of this payment, sometimes called a tip. This is to give you just some overview of Hungarian health and economic statistics, which is to say that by various indicators, Hungary spends a lot less money than other OECD countries on healthcare. There are less quality by some measures here by life expectancy. Yet there is access to physicians. There have equal access to physicians compared to other OECD countries, 3.1 to 3.2. There are also actually a high number of hospital beds, and there are high numbers of doctor consultations, but having more beds and having more visits doesn't necessarily translate into increased quality. This is new to me. So, I'm so sorry, the flashing of the text was not my initial programming. So in terms of the overall magnitude of what these informal cash payments account, some 235 million euros exchange hands in Hungarian healthcare. Those are estimates from 2007, which accounts for about only 2% of all healthcare expenditures, but that still makes up a significant portion of physician salaries. So it can make up to 60 to 236% of physician salaries, but only a small proportion of physicians get benefit of this cash payment. So 60%, 5% of physicians get 60% of the cash payments, and those 5% of physicians frequently are surgeons and obstetricians. Officially, in the legal code in Hungary, these cash payments are not legal, but there's kind of a loophole that employers can have the right to dispense their employees from being responsible or culpable in gathering these payments. So there's a little bit of a double standard. The Hungarian Medical Association feels that these informal payments are related to the low salary of physicians and dysfunction in the system. In the public discussion, these payments are very much part of the dialogue around birth in Hungary and in healthcare in general. This website, which says ipaid.hu, is generally about these cash payments in healthcare, but there's an entire way to search for these payments related to birth, and that's what I have pulled up here. And there's numerous instances of people sharing stories about these payments. In the region, this is from a report that compared informal cash payments in childbirth across countries. So here you can see Bulgaria, Hungary, and Ukraine. This was from 70 Hungarian women sharing their experience. So you can see that the way that Hungary differs from these other countries is that many of the payments are informal and in cash. Whereas, for instance, in the Ukraine, there is a smaller proportion of the dark blue informal payments, and they're kind of quasi-formal and informal, where people might make cash donations to the hospital. In Hungary, a lot of the cash goes directly to physicians. So while these payments are common in the region, they have kind of different textures to them. So in our survey, when we were adapting the American and Canadian maternity surveys, this was a huge topic we knew we would have to develop material for. There were other surveys that had been conducted by Petra Bai, the economist, but that had been, her questions were only for general inpatient hospitalization, so we adapted them to childbirth, and we had 9 questions about it. We asked women how much they paid, when they paid, to whom, how they felt about the payments, and also importantly, what they thought they would get back when they gave the payment, whether it was better quality care, more attention, having the same provider attend their birth. So just to review quickly again, we had very different groups of women respond to our survey. We had the group of women who were concentrated in Budapest of higher education and higher socioeconomic status, and then our survey firm group who was maybe perhaps a more representative spread. For that reason, in the payment analysis, we focused on the more representative sample, the 600 women. Again, their birth outcomes were also very different. In the sample that we're going to look at, there was a 41% cesarean section rate. So this exchange of cash was very important to defining our provider types for the survey. So the ways that we categorized the doctors and the midwives in the survey that women selected were completely defined by how the cash flowed. So this is just to stress that it's a completely pervasive way that obstetric care is given in Hungary right now. So that's what this slide indicates, is that all of the chosens, this is translated from Hungarian and English, of course, indicate some mode in which cash is exchanged informally. And you can see that the majority of women, even in the survey firm group, which is of a lower socioeconomic status, still have chosen doctors as their majority of care, about 60%. And that about 25% are doing the state care, which is the free form of care. So this is our pathway down to 600, and of those 600, 469 women gave an answer to the question. We think that perhaps 130 women dropped out because it may have been a sensitive question to answer. So this is where I think it gets really interesting. So of the women who answered the question, 57% paid, and on average they paid 180 euros for their birth care informally. You can see on this slide that the higher educated you were, the more you paid. So at the higher end, you can see that the high school graduation, college diploma, upper level education, 72% of those women paid, and on average they paid 200 euros. Also, the cash payments tended to increase in amount as you got closer to Budapest. So you can see in Budapest, 71% of the women paid, and they paid 241 euros informally. I please add, these are preliminary results that we have not published. So I ask that if you don't take pictures of them or share them. I'm sorry, I just saw some of you picking up your phones. Unfortunately, we do have to think about that. But I'm glad you're excited and interested in these. So, okay. Next, we can see that in terms of the chosen doctor, that's the main thing that women are pursuing with these cash payments. So if you contracted with the chosen doctor, 78% of those women paid, and they paid higher, 191 euros. Women who didn't have a chosen doctor, 20% of them paid, and they paid 110 euros still, actually. So there is some level of cash even that exchanges hands even when you don't have a chosen doctor. But if you have a chosen doctor, it's more. You can see here that there isn't a very significant difference between how much cash women pay when they have a cesarean, when they have an episiotomy. There may be a significant difference for epidurals in the amount of cash that women paid. So you can see here at the bottom then that cesarean rate is much higher when you have a chosen provider. The epidural rate was the same. The episiotomy rate was the same, excuse me. The epidural rate was slightly higher with the chosen provider. But a challenge in looking at these numbers just in the raw data is that there could be other factors that explain why a chosen provider has a higher cesarean rate. Maybe they get women with more medical risk factors, maybe they get women at a higher age, et cetera, et cetera. So we're developing a statistical model to try and explain, what these factors might be. This is what our model potentially looks like, and I'm just going to go a little more quickly. So what we found in the first regression analysis is that there were a number of factors such as higher age, higher education, lower number of pregnancies, and having increasing cesarean, increasing episiotomies, health problems, and satisfaction with your birth. All of those were significantly related with paying an informal payment. But when we added the chosen provider to the model, all of those other factors were obscured by the magnitude of having a chosen provider. That's to say that when a woman contracts with a chosen provider, all of the other factors that are highlighted here on the left become less important, and that the factor that is dominant is when you contract with a chosen provider, it actually increases your risk of having a cesarean section. We can't comment now on the magnitude of that association, but it appears to be the strongest factor in this population of women, along with, I should mention, and saying that there is a health problem. So I think that as a challenge, this really complicates our idea of how to what is choice? And we've been talking a lot about that language in the Tarnowski decision, that women have the human right to choose the circumstances of childbirth. But we see that because of these two different systems as they exist in Hungary, this cash system and the state system, is, what does choice mean in this situation where some women feel very satisfied with their use of cash to contract with a doctor, but it may actually be putting them at risk for unnecessary procedures, while at the same time they feel like they're enacting their human right to choose. So I propose that as a challenge. As policy recommendations, we have these recommendations: to improve quality, to regulate these charges, to ban informal payments, to educate women about the negative effects of these payments, and to have increased funding of quality maternity services in Hungary. So thank you.
Thank you very much, Nick. We look forward to the publication. Okay. You're the next one. And then I think yours is in this list, is it not? Yes. And then that means you can use this to click through. I think it's, if you click right, you'll click through your slides. Yeah. I'll just introduce you. So next, I'd like to introduce Diana Duake from Hungary. And she is both doctor and trainee obstetrician gynecologist who has recently defended her PhD on the topic of non-medical factors in the background of caesarean sections in southeast Hungary. And she is going to tell us a little about her research findings.
Thank you very much. Do you hear?
No, you need this.
No? Okay.
You need this.
Okay. Good afternoon, everyone. It's really nice to be here and a great honor for me, especially that I'm a practicing obstetrician. I would like to talk about the results of two questionnaire surveys performed in southeast Hungary, one among obstetricians and the other among pregnant women. And the topic is non-medical factors in the background of caesarean sections. As in many countries, Hungarians also have witnessed dramatically increasing caesarean section rates since the late 80s. As you can see, in 2012, every third Hungarian woman delivered abdominally, which is quite far from what the WHO statement in 1985 said about the optimal caesarean section rate. It said that no additional benefit or decrease in maternal and neonatal mortality and morbidity is provided by a caesarean section above 10 to 15%. Of course, there has been a lot of changes since 1985, and we can say that there has been dramatic demographic changes since then. For example, the average age of first-time mothers in Hungary is around 30 years. There has been incredible improvement in medical technology also, and no one doubts that caesarean sections have become safer since then. And we can also talk about the threatening medical legal environment where the doctors have to work. But are there crowds of women who ask for unnecessary caesarean sections without any medical reasons? And do they get what they want? The official answer is no. According to the Hungarian Colleges of Obstetricians and Gynecologists, sorry for the misspelling, in Hungary it's not a legal option for a woman to choose the way she wants to deliver her baby. So we wanted to see the background of this, or what happens in reality. That's why we first performed a questionnaire survey among Southeast Hungarian obstetricians and gynecologists, and we wanted to know more about their opinion on women who ask for cesarean section without no firm medical reason, and also their personal opinion or about their willingness to perform such procedure. The next questionnaire survey was performed 2 years later, and at that time we asked directly pregnant women about their childbirth preferences, and we also wanted to know what factors lie in the background of a preference for cesarean section or ambivalent childbirth preference. And we also wanted to know whether there is any relationship between mid-pregnancy childbirth preference of these pregnant women and the mode of subsequent delivery. So I would like to talk first about the first questionnaire survey, which we performed in 2010 among those obstetricians who worked in the 12 who work in the 12 obstetric departments in the southeast region of Hungary. I would just run through the results. According to our respondents, the ideal Hungarian cesarean section rate would be around 26% on average, which is less than the 33% which was the Hungarian cesarean section rate at that time in 2010, but much more than what the WHO proposed. According to them, 1 in every 10 cesarean sections are possibly performed without firm medical reason, just upon a maternal request in Hungary. And they also believe that 1/4 of first-time mothers would prefer cesarean section to vaginal delivery. They also believe that in the background of such a preference for cesarean section, there is a fear of long-lasting and painful labor on behalf of the pregnant women, and also the worry about the health of the newborn baby. These were the most important of these. When we asked them whether they feel the need for an indication that would legalize cesarean section on maternal request in Hungary, more than half of them said that there won't be a need for such an indication in Hungary, but more than a bit less than 1/3 of them would like to see such an indication, so that they would feel the need that it would be legalized in Hungary. However, more than 80% of them would be ready to perform such a procedure in case it was legal in Hungary. And among them, 17 respondents would even suggest this option to his or her patients. Now I would like to move on to the pregnant women's questionnaire survey, which took place on the turn of 2011 and 2012 in the Department of Obstetrics and Gynecology, University of Szeged, Hungary, which is a university clinic. We recruited women in mid-pregnancy, and only those were excluded who were younger than 18 years, who couldn't read or speak Hungarian, who were bearing high-risk pregnancies, who were aware of any valid information that they won't be able to deliver vaginally because of medical reasons. This was a follow-up service, so we had the first questionnaire in mid-pregnancy at the time of recruitment. The second questionnaire was quite close to the time of delivery in the 35th to 37th gestational week, and this time I won't talk about the postpartum questionnaires. During these 2 time points of the 2 questionnaires, there was of course a significant dropout due to abortions, premature labor, moving to another town, rejecting to further participate in the survey, and we excluded further 14 women because they learned that they won't be able to deliver vaginal because of medical reasons. Just a few words about the questionnaire. Of course, the first and most important question of these questionnaires were about the childbirth preference. We also wanted to quantify the level of fear of childbirth by a psychometric tool called VIMA delivery expectancy and experience questionnaire, which was translated into Hungarian, but it hasn't been validated so far. That's why we used only the crude scores reached on this item. We also had 33 statements in this questionnaire about maternal attitudes toward childbirth issues, which were later then grouped into 8 groups, 8 principal components by statistical method called principal component analysis. I'm going to show you this just to be able to see what they mean. So these are 4 of them, and under every principal component you can find a characteristic statement from the questionnaire, and these are the next 4 of them. Okay, and here are the results. The green bars show those women who were consistent in their explicit preference for vaginal delivery in both time points, so both in mid-pregnancy and in late pregnancy. As you can see, these are, in case of first-time mothers, this is more than 80% and a bit less in case of porous women. The yellow bars show all the other women, so those who at least one time point expressed explicit preference for cesarean section, or at least one time point skip this question because of uncertainty. Okay, in order to find the most important factors in the background of a childbirth preference for cesarean section or ambivalent preference, ambivalent childbirth preference, we performed a binary logistic regression analysis with the following variables, and these are the results of this analysis. Sorry for the table. This is a quite strong model, quite powerful model of the first-time mothers model. It means that in the background of preference for cesarean section or ambivalent maternal preference, you can find the very strong belief that the cesarean section is less risky or less harmful than vaginal delivery. You also find that we can also see that there is a strong environmental influence in the case of these women, a kind of pressure on behalf of the family members, husband, or even the doctor, that cesarean section would be a better option for them. And it's quite interesting that what prevents women from preferring a cesarean section is if they are, well, control freaks. So if they like to keep their events under control. 5 minutes. 5 minutes, okay. In case of porous woman, the model was even more powerful, and again we can see the effect of the belief that cesarean section is more beneficial than vaginal delivery for them or for their baby. We can see that there is an effect of previous negative experience in maternity care or generally in healthcare. But the most important of all these factors is if somebody had a previous cesarean section. So it's very possible that someone will prefer cesarean section in the next pregnancy. Well, this is not a surprise. Okay, the second analysis of the data of pregnant women was aimed to identify the most important factors, that non-medical factors that determine the mode of delivery. For this, we used only the mid-pregnancy questionnaires with all the information that we gained from the questionnaires, and of course we needed information on mode of delivery and other obstetric data, such as personnel being present at the delivery and the time of delivery. And here are the results. As you can see in this case, well, it's not shown, but more than 90% of women in mid-pregnancy preferred vaginal delivery, and on the other side, okay. So these are who preferred vaginal delivery, and these are those who preferred the cesarean section or were uncertain about their preference. And the final outcome is that exactly 2/3 of our respondents delivered by vaginal delivery, and 1/3 of them delivered. So this is this 33%. We again performed another logistic regression analysis in order to identify those non-medical factors that can lie in the background of delivering by cesarean section. And what we found in the case of first-time mothers, that they were more likely to deliver by cesarean section if their obstetrician had the power to decide upon cesarean section, if there was a longer time to pregnancy interval, and they were less likely to deliver by cesarean section if they like to control the events of their lives. And in case of birth woman, the model looks like this. Again, the belief that cesarean section is more beneficial than vaginally. Those who believe this were more prone to deliver by cesarean section if they had an older obstetrician, if the woman's age was younger, the woman herself was younger, and again we can see the effect of environmental influence. In both models, I would like to highlight that neither in case of explaining preference for cesarean section nor in case of delivering by cesarean section, we couldn't find the very important role of fear of childbirth, which one might have thought. And in this case, explaining delivery by cesarean section, we couldn't find the effect of fear of childbirth or higher scores reached on fear of childbirth, and nor the effect of preferring cesarean section in mid-pregnancy. So the cesarean sections were not in connection with the mid-pregnancy preference for cesarean section or uncertain preference. So I would like to conclude finally my presentation. According to our respondents obstetricians, 1/4 of first-time mothers would prefer cesarean section to vaginal delivery, and they believe that the most important motivations in the background of maternal preference for cesarean section are fear of painful and long-lasting labor and the worry about the health of the newborn. More than 1/4 of them believed that there was a need in Hungary for a legal indication to perform cesarean section without a firm medical indication, and 4/5 of them would have performed cesarean section in case it was legal. And about the women, in mid-pregnancy, the vast majority of them preferred vaginal delivery, and they were more or less consistent in this preference throughout their pregnancy. And we found that the primary cause of maternal rejection of vaginal delivery wasn't fear of delivery, but the belief that vaginal delivery is risky. And in the background of cesarean sections, neither maternal childbirth preference nor fear of childbirth were important independent non-medical predictors. Thank you very much. Sorry if I was too long.
Thank you very much, Diana. That was a very interesting presentation, and throws up some interesting questions. I think in particular in the light of the WHO's restatement of its 15% cap in terms of improvements on health outcomes in the last month. Okay. There'll just be a short pause. Are you coming up now, or are you going to come up in the... No, okay. Maybe Nicola, if anybody has any questions. That's a good question. Would anybody have any questions that they'd like to put to the panel so far while we're waiting? Jette her hand has shot straight up. Even better.
Diana, it's a question for you. I'm a Danish midwife. And I was thinking about, while you were talking here, because very often in obstetrics or in midwifery conferences, we have these discussions about vaginal delivery versus cesarean delivery. But today we are in this setting where we talk so much about violence and abuse. And, then the question kind of arises, when? These women who have this belief that vaginal birth is more risky than cesarean section. So what then? When settings are so extremely different. So what, in your context, do you think that these women's beliefs are also colored by the violence that it is in the Hungarian system?
I think if you press a button on the...
Do you understand? It makes sense?
Maybe partly, but maybe partly. But
could you say a little more?
What I think it's because of the normalization of cesarean section. Mm-hmm. You see these high rates. Yes. So these high rates suggest that this is an alternative of vaginal delivery, and because the indications that have risen dramatically, indications for cesarean section are acute distress, acute fetal distress or compromise, and I don't know, cervix dystocia, and all these indications. That's why I think that many women simply believe that these cesarean section happen in order to save women's and the baby's life. And if there are crowds of procedures that are explained by these indications, then many women will believe that cesarean section is really more healthy than vaginal delivery. That's what I think.
But in Denmark we had this. There was at one time this study that showed that women who wish for cesarean section in subsequent birth, if you look into their reason, it has often to do with that they have bad birthing experiences. So I'm thinking about, what might it mean in Hungary if you are giving birth first time with cristella and episiotomy? Would you wish for a cesarean section on the second time around?
Yeah, that's why we put in the fear of childbirth questionnaire, and we thought that we will see the effect of it. Yeah, and there is something, but this is not the most important.
But what made me think, was when I saw this question in your questionnaire, women's fear of childbirth pain. But often when we say childbirth pain, we think of contraction.
Yeah.
So I couldn't distinguish between that question, fear of contraction or fear of how birth is conducted. And that is different types of fear.
Okay.
Yeah, I totally agree.
Thank you very much, Jette, for a very interesting question. And I think we need to move on, but it does raise a lot of very interesting questions, I think, that presentation. Okay, next I would like to introduce two people. They're going to speak on the subject together, but Fleur is going to start, and Zeynep is going to follow on. So they've come to see us from Turkey. They're both human rights professors in one of the universities in Turkey, in Istanbul, and they both have focused during their careers on extensive research, which has then led into lobbying for NGOs and working for UN bodies to try and bring these all of the conclusions that they have come to the attention of the right people. So Fleur is going to start, and they're going to look between them at the current situation in Turkey and what it means for birthing women.
Thank you. Let me put this
I'm going to put it a little bit here, and then I hope the translator can hear me as well, because I have to turn my back a bit to you. I'm sorry. But I have to look here because I cannot see it on the screen here. So I was asked together with Zeynep to say something about the situation in Turkey. And to start with, it's been very inspirational today because we heard about these studies that have been conducted and these surveys. And one of the problems in Turkey is that we don't have these surveys yet. So the data that I'm going to show you is basically a compilation of OECD reports, World Health Organization reports, and some independent studies that were conducted by researchers. So I just compiled it just to give you an overview, I hope, of the current situation in Turkey, and then I'll place it against the background of the ideology that is basically supported by the current government in Turkey, just to give you an idea as to why these laws and regulations are put in place at the moment, or at least we think that's one of the reasons, right? So what we're basically going to focus on is a law that that was adopted in 2012 concerning a prohibition of C-sections that are not medically necessary. My colleague Zeynep Ünsal is going to talk more about the law itself. So she's going to talk about, well, what is and is not arranged in that law, because I have to say the law is still rather vague, but Zeynep will tell more about that. But so this law was adopted in regards to the high number of C-sections in Turkey. The number is higher than 50% at the moment, with a number that reaches almost 70% in private hospitals. So what I would like to do, well, we're going to argue actually that the law is against women's human rights, but hopefully we have time for that to get to that part. So I'm going to give you a general overview of birth practices in Turkey. Where do women generally give birth? What are the numbers? What is the population? And I'll say a little bit about the health transition program that was installed by the government in 2003 to improve, amongst others, maternal and child health care. Then I'll look specifically at the problem of the C-sections, mainly the high rate, and the government response to that. After that, a little bit of a look as to what the government has said in the media, especially. You might have seen some images of our famous or infamous president Recep Tayyip Erdogan making some controversial statements, I should say, and then look at some laws and regulations that were adopted in order to promote motherhood, or as he claims, in order to promote population growth. And if we have time, I said it before, just a brief notion as to why this law is actually a violation of human rights. And then Zeynep after me will talk more about the law, how it's actually functioning, how doctors are punished or are not punished, etc. So this is Turkey. I'm sure you know where it's located. It's composed of 81 regions, and there's a big diversity. It's a very big country, and there's a lot of diversity amongst the regions. So, for example, I don't know if I have it here. Well, actually, the neonatal rates and the maternal mortality rates differ per region. So this is just the overall vision that I'm giving you, but there are many differences between the different regions, and generally the southeast of Turkey is a lot poorer than the western part of the country, for example. There's a population of almost 75 million people, and as you can see, I put the ratios there of neonatal mortality, the neonatal mortality rate and the maternal mortality rate, and you can see that it decreased significantly, and this is arguably due to this health transition program that was adopted in 2003. Now, this program was really focused on increasing the accessibility to hospitals and to healthcare everywhere in Turkey, especially also in the eastern part of the country, and to increase the number of services, especially in state hospitals. The number of private hospitals wasn't that big yet in 2002. The number of private hospitals has increased tremendously since then, with 90%. Also actually in the eastern region. But the idea was just to increase access, so to have more hospitals, which is what the government actually did. They put a lot of money into it. And to increase the number of services. So what they did is doctors from then onwards were being paid in state hospitals, I have to say, for the number of services they were performing. So it was really a quantity-based program, increasing the quantity of healthcare basically in the country. There wasn't a focus on quality yet. You could argue that that has to be the next step, and focusing on the outcomes of these programs. But this was their aim, and there was a special part dedicated, or a really important part of the program was to increase the child and maternal health services available. So what happened, for example, is that they installed a system of family practitioners, which had to be located in every region, in every small environment, and they have to provide child and maternal health care services. And if they wouldn't do that, if they, for example, wouldn't give information about breastfeeding or about maternal health services or contraception, they would get fined. At least that is what was stipulated in the program. I have to say, in Turkey, it's always rather unclear whether something is actually regulated or not, and if it's regulated, whether it's put into practice. So, but this was the plan. This was what was in the program. And well, the numbers came down, as you can see. So there you see this is probably related, right? The proportion of women that received skilled care during birth increased as well after the initiation of this program, and more women gave birth afterwards in healthcare institutions. So as you can see, home birth is really a very small percentage, because 79% of women, according to the data, give birth in hospitals. In Turkey, home births are very much associated with the southeast of the region, and the reasons that are being given in literature is that the women either don't have the economic means to give birth in a hospital, which is actually not a valid reason anymore, because due to this health transition program, there's universal coverage, meaning that everybody can go to a hospital for free. But they argue that not all women are probably aware of this, which might still explain the number of home births. And also the reason that was being given is that women choose to give birth surrounded by neighbors, family, and friends. And they fear that they cannot do that in a hospital. But it's a very small percentage. So in Turkey, as far as we are aware, there isn't any trend amongst women, especially not the higher educated women, to say, well, actually, I want to give birth at home. It's actually the other way around, as I'm going to show you with the numbers. There's the numbers of, for example, C-sections is a lot higher amongst the richer and educated women, but we'll get to that. So these are the numbers of private hospitals. So there's a system of private hospitals and state hospitals in Turkey. And as I said, the number of private hospitals increased significantly over the last decade. Now, in theory, everybody can, of course, go to a private hospital. But in a private hospital, you have to also make out-of-pocket contributions, and they're quite significant. So in practice, you see that it's mainly the richer part of the population that makes use of private hospitals. Yeah, this is just, I don't really have to, this was part of, this is what the government claims they did, but I don't really know if that's true. I put it in for now. Some incentives for women, for the whole maternal and child health care safety. These were some incentives. But let's go to the C-section rate and the enormous increase actually that was witnessed. So in 2006, it was almost 300 out of 1,000. But as you can see, in 2012, it was 51%. And then if you compare, there's three types of hospitals actually. There's public hospitals, there's private hospitals, and there's university hospitals, mainly for research purposes. But university hospitals are actually part of the state hospitals, you could argue. So you see that private hospitals, but also university hospitals, have a very high C-section rate. Now, the government claims, basically, with this high C-section rate, that it's all due to the privatization of hospitals, right? So they say, we see this 90% increase of private hospitals, and we see this increase in C-sections. There you have it. These doctors are greedy, and they just perform C-sections. But if you look at these numbers, you see actually that the university hospitals still have a very high rate as well. So there's probably more that causes these numbers. Now then, who are these women that have these C-sections? There was one, I could find one study that was conducted on this, and these were just some of the differences that were witnessed amongst the women that had C-sections. So you see an enormous difference between women without education and with higher education, between the poorer section of the population and the richer part of the population, which might also, of course, have to do with those women going to private hospitals where the ratio is higher for C-sections, but this is pure speculation, like I didn't do research on this topic. And a difference between the western part of the country and the eastern part of the country now. And the urban and rural. And then, of course, there's also the numbers that the older the women get, the more likely that they have a C-section. For example, if they have a multiparous pregnancy, there's an increase, of course, in C-sections as well. So what was the response by the government of Turkey to this high C-section rate? They decided to prohibit C-sections when they were not medically necessary. Now I said I'm not going to go into the law because my colleague and friend Zeynep is going to do that. But this is what was mentioned in the news at the time. Now interestingly enough, the government always does controversial things together with other controversial things, so you can always cover one up. So when this happened, they also said that they were going to prohibit abortion. So at the time, the attention of women's organizations was very much on getting their right to abortion back and preventing the government from introducing a prohibition on abortion. So there wasn't actually that much outcry over this new law, the C-section law. There was, however, a response from the president of the Obstetrician and Gynecologists Association in Turkey, and he said, well, it is very interesting that 2 years ago, I think, our association presented these recommendations because we also recognized that the level was too high, so we came with recommendations. The government never did anything with it, and now they just come with this prohibition. And I wanted to mention this because, according to this association, one of the reasons for the high C-section rate is that the number of malpractice cases against gynecologists in Turkey is, they argue, really high. Now the problem is that we cannot check that because in Turkey you don't have access to case law. So you have to ask the government for access to case law, which usually you're not granted. But this is what they said. So they said doctors are really afraid that they will get a malpractice case lawsuit after a vaginal birth. So they argued that there should be legal efforts to help these doctors with that. This is just one of the issues. Maybe I should wait before I go there. Oh, really? Oh, I have to finish up. Just quickly, I wanted to go to the midwife section. There is a midwives association in Turkey. There's 51,000 of them, which on a population of 75 million, I don't know the ratio in other countries, but they argue, they gave a statement also after this C-section. They say, we are not asked to help enough with births. We are given the role of nurses instead of midwives during births, and they could increase our role in that area. And then I'm going to wind up. I should say something about this. So Turkey's promotion of motherhood, right? I'm not going to show you this video, but maybe you saw it on, our president said women, he doesn't believe in gender equality. It's a false notion of the French Revolution. And well, there's a role for women, which is motherhood. You get the general idea. I have some more infamous quotes by our president. And it is actually really funny. The sad thing is that he is a really powerful man in Turkey. He is the most powerful man, you could argue. I'm looking at Zeynep if she agrees. But yeah, the new laws that are adopted are in line with this reasoning. So just to mention some of the practices and the laws and regulations that were adopted in the last couple of years. So as I mentioned, of course, there is the prohibition of the C-sections that are not medically necessary. There's a new abortion law from 2012 as well, in which they reduced the number of weeks for abortions. Zeynep will talk more about it. And there is a plan for even much more restrictive abortion law. Misoprostol was banned, which used to be available, of course, as in other countries at the pharmacies. It's no longer available. And recent studies conducted by women's organizations in Istanbul pointed out that already de facto abortion is no longer available at state hospitals. Women are being sent away. There is an online registration system, or there used to be, for abortions, but now the online registration system is taken off the website. So when you go to the hospital and you say, I want to get an abortion, they say, you have to register online. Yeah, but I cannot register online because it's taken away. So it became de facto impossible to get an abortion at state hospitals, which is bad because, as you just saw, the poorer women tend to go to the state hospitals. They cannot go to the private hospitals. So they are the ones who end up either having to carry the pregnancy to term or having an illegal abortion. And there are some other practices that were adopted. Now, I don't really need to go into this. What I do want to focus on, the right to life, I just quickly want to make we have already heard in Turkey of some very sad cases that can arguably link to this C-section law. So when a C-section wasn't performed and which was a medical necessity, which is arguably because of the chilling effect that this C-section law has, because we see this in all these countries that have restrictive abortion laws, you see that the doctors become afraid to actually authorize an abortion when it is allowed under the restrictive law. And the fear is, of course, that the same will happen in Turkey with these C-section laws, or is happening already, and that women well, they might die, or there might be serious consequences also actually for the children that are being born. But this is something that we have to discuss further. So I'll stick with that, and I'll give the floor to Zeynep to tell you more about the specifics of these laws and what is arranged in them.
Thank you, Fleur. Hello, Zeynep. Okay. Yeah. Okay, and then.
No, it didn't work before. No.
Okay. So hello everyone. So I will just continue with what Fleur left, and I will briefly talk about this infamous C-section law in Turkey. But I chose this topic. I chose this title for the beginning of my slides because it looks like the Turkish government is in a position to call itself so powerful that it completely ignores about the woman's autonomy, and so it kind of says, well, what is woman's autonomy after all? I rule and I decide. So when we look at the C-section law from 2012, as Fleur already mentioned, it permits C-section only in the case of medical necessity. And it also envisages threatening fines for doctors who performed it against the law. So through this adoption of this law, Turkey becomes the first country to make elective C-sections punishable by law. And so in a way, it's not an outright ban itself, but when we look at it, it's a restriction, but in de facto, it's really kind of a ban because it has a truly a chilling effect on the doctors, which I'm going to talk a little bit more in a bit. But the vague thing about the C-section law, it just says that, well, C-sections shouldn't be done unless it's medically necessary. But we really don't know, and it's really not clear as to how and by whom this necessity requirement will be determined. And the rumor is that what we could follow from the press and also from the Gynecologists Association, a lot of files have been taken away by the Ministry of Health experts after the adoption of the law, from the private hospitals primarily, to see whether the C-sections have been performed according to this necessity rule. Of course, it doesn't have a retrospective effect, but after the adoption of the law. So, but still it's ambiguous, I mean, how they are going to decide the necessity. And this is something to be seen. And there are a lot of critics from the stakeholders, primarily from the Turkish Gynecology Association, as already Fleur mentioned, that they argue that very rightfully that they have been already doing a lot of efforts to decrease the C-section rate by taking other measures. And they proposed a lot of measures to the government, but they turned out to be futile. But all in all, also they argue that it's completely against medical ethics because it's an interference to the doctor's determination on the case. And therefore it makes a chilling effect on doctors. They are refraining from performing C-sections, even if maybe in the first place it would be decided at a earlier stage, and it therefore increases the risk of increasing mother and child mortality rates. And sadly enough, we have observed that there were already some cases last year where the doctors were reluctant to perform C-section, which led to the death of the babies in the delivery process. And another sad thing is that we really don't know about the outcome of the criminal persecution going on against and these incidents, because also as Fleur mentioned, that it's not that easy to have access to case law. You have to really find the lawyer who is representing the clients, and there is no common database where you can just Google and where you can just put these keywords in the general database. So we don't really know about the whereabouts of the case, so and it really requires further research, which we hope to compile at a later stage. But all in all, when we look at it, the Turkish C-section law has been really has been making this chilling effect on doctors. And also, ironically enough, Social Security institution, right after the adoption of the Turkish C-section law, reduced the state financial support for C-sections. So in a way, it also, in order to promote the law, it also reduced the financial aid for covering the C-section operations. And but of course, as it stands now, C-section is not permissible upon maternal request. There has to be this medical necessity. But fortunately, this was brought before the Constitutional Court by the major opposition party in Turkey. However, sadly enough, the Constitutional Court upheld the law already right after the adoption of the law, I mean, in 1 year time. But they only made their reasoning public 3 months ago, 4 months ago, by the end of December, which I was completely disappointed to read the reasoning of the Constitutional Court, because it really made a very strange legal analysis on the case, and it basically said that, well, there is no unlimited control and autonomy of the individual over his or her body. So, and this was part of the state's positive obligation. The state only wants to protect right to health and the physical integrity of the person. And C-section it's not that blunt, but it almost says that C-section is very dangerous, so it shouldn't be performed. And it also didn't find any correlation whatsoever between the law and the inviolability of the individual's integrity of his or her material and spiritual entity. This is a phrase from the Turkish constitution, that's why I put, but it basically means that the right to autonomy of the person and the law. So it didn't find any correlation whatsoever between the right to autonomy and the law. And on top of it, it said that if there is no such prohibition, it's going to be an interference with the doctor's freedom of work. And if the pregnant woman asks or requests for a C-section, it's going to be an interference with the doctor's freedom of work. So that's why we also have to put this limitation. So this is really completely outrageous, and it's, sadly enough, this is the final decision of the Constitutional Court. So it means that women's right to have autonomy over her body is completely ignored in the Constitutional Court's reasoning. But what would have been ideal? What would have been more ideal, that instead of restricting this C-section, like already Fleur said, and like already what the Turkish Gynecologists Association have proposed, Turkey would have done better in reconstructing a system. For instance, there is no proper midwifing system in Turkey. When I myself was pregnant, I was just under the examination of the doctor. I have never seen a midwife. So and then I moved to France, and all my friends in France, they are just under the midwife examination. So I was really surprised with the whole change of culture. And so it's very important, I think, that Turkey should do something about the midwifing system. And there is no pain relief method. It's also very, very, very insufficient. And also, of course, there is no really good information strategy on the normal birth and on the vaginal birth and delivery. So Turkey should do more. I should take a more holistic approach to encourage vaginal birth and to decrease the C-section law but instead it just chose this very strange legal way, which really doesn't solve the problem. And 2 minutes. Okay, very quickly. And there is one other very strange situation in Turkey, abortion. I just would like to say a couple of words about it. Abortion is legal since 1983, so it's almost over 30 years. It's legal up to 10 weeks. It used to be 12 weeks, but the Erdogan government reduced it to 10 weeks. And it's possible for up to 20 weeks in case of rape, for instance. But there's something very strange in Turkish law. If you are married, you have to take your husband's consent for performing abortion. And this is, of course, completely unacceptable. And there is also a controversial draft law, which also has a chilling effect on the performance of abortion. And I'm not going to go into it. We can discuss at a later stage. But luckily, it's not adopted as yet, but also it's not doing things any better. And there were some surveys conducted by the women NGOs in the country, and it shows that there is a de facto situation in the country that the doctors at the state hospitals, they are again refraining from performing abortion because of these draft law and these reluctance of abortion by the state. And also, it also creates an inequality between the social status of people, because women who are poor, they can't go to private hospitals, as Fleur said, and so they can't have access to abortion as easy as possible, so it promotes the back alley abortions. And I'm finishing my presentation just telling this very sad story very quickly. And this lady, who is a 24 years old Turkish woman, she had a terrible, tragic story. She was having a divorce proceedings for a long time, but in the meantime, she had another boyfriend, and she fell pregnant with this man, who also turned out to be, unfortunately, a very abusive man. And this man killed her mother, and she was shot by this man. As you can see here, that she had this terrible wound on her arm, and she was hospitalized, and she wanted to have an abortion. And but the doctors, because she was pregnant, she was not given any proper treatment because of the pregnancy, because of any because of the infections she had. She couldn't have proper medical treatment, and because she's married on paper still, she was not permitted to have an abortion. And of course, it created a big uproar in the country. All the women's NGOs, stood up for her rights. And in the end, she had the abortion. But the whole story was like, I was almost like, jumping out of the window, and I was following up the news because it's all like an incredible story. So all this stupid bureaucracy and it's the ignorance of the states for women to have full control over her body is unacceptable, and that's what we have to tackle with in Turkey. Thanks a lot for your patience, and let's talk later.
Thank you very much to the two of you from Turkey. Clearly interesting times and difficult times in Turkey. Okay, next we have Erika Schmidt. Okay. It's yours in the main list. I'll just introduce you while you're doing it. Erika has come from Hungary. She's a mother of three, activist, educator, and lecturer. And Erika is going to present to us on her work with the specific problems and needs of Roma women in Hungary. Thank you, Erika.
Thank you very much. I have to tell you that it's always a bit frustrating to speak right after about researchers and lawyers, as an activist. But I hope that it will give you a kind of break to see my presentation, as I have brought you a different type of presentation. So I'm Erika Schmidt. I'm representing Birth House Association here now, a Birth House Association from Hungary. Birth House Association is a small women organization dealing with birth rights and birth justice in Hungary. When I was preparing for this presentation, I thought that I will tell you more about our running projects that focus on Roma women. But listening to the presentations in the morning and in the afternoon, I decided to share you some challenges that we face as an organization recently, and these challenges are connected to our Roma projects as well, so you won't lose your interest. So we are dealing with birth rights and birth justice. Within the legal framework dealing with birth rights, we try to protect the individual women's right to reproductive decision making, especially their decisions around birth. But by enhancing birth justice, we aim to dismantle inequalities of class, gender, ethnicity that systematically may lead to adverse birth outcomes and negative birth experiences of different groups of women. The scope of our activity is pretty wide. We conduct information campaigns to raise awareness around birth rights and evidence-based maternity care. We participate in birth-related surveys, and we also engage in lobbying activity to promote and attain the societal acceptance of natural childbirth in Hungary. And we also provide legal aid service for women and for professionals. I'm very happy that we have other fellows who are from Hungary as well, because now you can get a very nice picture of Hungary, what type of problems we face. Yes. Wow, it's a bit bigger than I expected. As you may all know, first time in Hungary, the issue of home birth and the case of Agnes Gerib, cases around Agnes Gerib, generated a very strong professional and social cooperation. It was really unprecedented in its kind. As a result of it, in 2011, home birth became a real and legal option for Hungarian women, and up to now we have 4 legally working home birth care providers in our country. However, sadly, Agi Gerib's situation is still not cleared, and she stays facing ongoing criminal procedures. The association, together with the home birth parental movement, take a great part in the campaigns around home birth, around the legislation of home birth and around Agi Gerib, and I'm sure that Nick Thorpe will share you more about this period of the Hungarian movement in his workshop. Yes. So right after 2011, and when the home birth services got established in Hungary, the scope of the association's activity embraced the issues around hospital birth. So we started to focus on issues around transparency, accountability, hospital statistics requiring public data, in supporting women in making their informed decisions. Yes, sorry. And in the meanwhile, we got contacted with different other women organizations in Hungary who deal with disadvantaged groups of women, especially Roma women. And during the conversations with them, we realized that these vulnerable groups of women suffer from a cumulative effect of the present maternity care system in Hungary. So in 2013, the association started a small project called Diversity and Access to Maternity Care. The main aim of the project was to examine and assess the real situation of different groups of women who are at a disadvantage in the maternity care system from different perspectives. So we organized 5 conferences, 2 of which highlighted the situation of Roma women in Hungary. The main aim of these conferences was to get stakeholders and women at the same table and initiate conversation, open, wide-ranged, interdisciplinary conversation. We wanted to get women's voice heard somehow. We wanted to have the stakeholders understand deeper women's perspectives and women's opinions about the maternity care they got. So we made an open call to professionals, and it was a great success. Many professionals came. There were family health nurses, midwives, social workers, patient representatives, lawyers, sociologists, researchers. Unfortunately, not a single obstetrician. Yes. The experiences and consequences of these 5 conferences made a solid base for our running projects. And about the consequences of this small project. What we saw on the surface is that there is a correlation between the rate of the Roma population in a region in Hungary and the rate of premature birth, low birth weight, and perinatal mortality. And we could also observe that the rate of seeking and using maternal healthcare services among Roma women is lower than that of the majority. And the international literature shows very clearly that these phenomena can basically relate to the extreme poverty and segregation, so the circumstances in which these women live. And it's not about their ethnicity. And it was a completely new message to most of the professionals. Maybe it can shock you because it's something that is clear on other parts of the world, but it was really a new information in Hungary for the professionals who attended the conference. I mean, yes. So the problems these Roma women may face, as for causes and risk factors, here I highlighted those factors that were important, that became important for us as an organization. So there are many others except these, of course. One of the biggest problems is the access to maternity care. And you shouldn't think about complicated things. So it's very simply about the access to the public transport, the money, whether they have money to cover the costs of travel or not, how to make an appointment at the maternity care, how to get to the hospital, how to find the proper place where they can meet the doctor. So these are very practical things that were coming up all the time from these women. Another type of problem that they generally face is the attitude of the health professionals. You should know that the Hungarian Roma community is not homogeneous. I've always struggled with this word. So we can't talk about the Roma culture in terms of tradition as strength for community, you know, for the Roma community, and as the core of the Roma identity that could give stability to the community. But we should talk about subcultures at local levels, And these subcultures are mainly characterized by poverty and segregation, and not by their Roma tradition that they may insist on or insist to. So, yes, 5 minutes, okay, thank you. However, there are some concepts and preconceptions of these Roma women around health, sickness, and medical care that could present a barrier in communication with the health professionals. Besides these cultural barriers, what's also a great problem is regulatory approach of stakeholders, by which I mean that it is very general that professionals try to force Roma women to cooperate instead of working together as partners, you know. And the most common mean to force these women to cooperate is to threaten them by getting their child away. It's really common in Hungary. I'm sure that thus the Hungarian Civil Liberties Union could tell you more about these cases. So I think it's not something that we should explain, that why it is difficult to cooperate with someone if you don't consider him or her a partner, an equal partner of you. As for support, so these women have these women face lack of information at many levels. They don't have internet access, of course. They don't have proper informational materials at the proper language that they can easily understand and easily follow. And usually they don't have any personal contact to, so there are no women in the community whom they can easily reach if they need support around their childbearing period. So together with professionals and women, we identified 2 principles that should be considered when you are trying to work together with Roma women. One is that you always have to consider local features. So of course there are general problems that Roma women may face, but you always have to talk to the people who live in that special area, and the professionals, and especially the social workers who have a good relation to the community. And of course you always have to involve the women themselves, because they know the best for themselves. So I think that's also a general problem in Hungary, and that the majority tries to tell to Roma women that what is good for you, but it's not the question at all. Roma women know very well what is good for them. But there is a problem at our side, that it's difficult for us to believe that they know what they want. And it's difficult for us to understand their points, because we have a very different social background, and we socialized under very different circumstances. And it's always something that we have to consider again and again, and we have to remind us again and again. Yes, that's it. So we are running 2 projects now, through which we try to support Roma women. One focuses on stakeholders, which is birthing justice, and it's funded by the Open Society Foundation Budapest. And the other is focuses on women, and it's funded by the Norway grants. And these are the main activities within this project. With the professionals, we are organizing local professional meetings. So it's absolutely a priority for us to get these stakeholders together and encourage them to communicate in a very open and in a very open manner. And we always try to promote good international practices from Belgium, from the UK, from Sweden. Within the Take the First Step project, we would like to establish a pilot project within the Roma community in the countryside, namely establishing a local peer-to-peer support service. And the main idea is to find at least 1 or 2 Roma women within the community who can be strengthened with information and different means to help her peers and fellows within the community. And we are also collecting 15 narrative interviews in 3 Roma communities. These we intended to conduct in-depth, fully unstructured narrative interviews, but that was that was a preconception of middle-class women that it could work within this community as well. So we have to reconsider our methodology, and I think a semi-structured interview could work with these women. So it's not easy at all for them to talk about their feelings and experiences in a way that middle-class women do. Yes, that's it, basically. And one more thing that may I have one more minute? That it is absolutely a historical moment in our association on one hand to start this type of job with Roma women. So it's not natural at all for us who are coming from the middle class that we are able to give real support to them as peers. So we are not professionals, we are not midwives, we are not family health nurses, we are not obstetricians. We have the chance to build with them a relation which can be based on trust and equality, and we are very excited in which direction we will go. Thank you very much for your patience.
Thank you, Erica. We have 2 speakers left, I think. 2 speakers left? Well, panel? I have listed Mary Short and Lucas Johnson. It's tomorrow. You've got the wrong page. Maybe you're not looking at okay. In that case, we're finished. Yeah, we're finished. That's good. Yeah, but aren't you tomorrow, Mary? Hold on.
Okay, I apologize. It's my fault. I ordered the coffee and the coffee is hot. We're running a little late today. We still have a lot of work to do. So I have 2 very important things to say. The first one, after the coffee break, there's going to be one talk in Croatian. So perhaps you can borrow the headphones of your neighbor, or if you haven't got headphones, now's the time to get them. And the second thing is the coffee break will only be 20 minutes because we're running late. So when I call you, please come back right away. Okay, thank you.